It's Jihad Al Ali from Aga University, Concept of Human Physiology 2, Dr. John Tyson, and today we're going to talk about the renin-angiotensin-aldosterone system, RAAS, and its effects on blood pressures as a part of urinary presentation. So without further ado, let's get started. The renin-angiotensin-aldosterone system is a hormonal system that controls blood pressures, while Paroreflex is a short-term response to certain changes in blood pressures. RAAS is responsible for long-term regulations. In the kidney, within the walls of efferent arterioles, there are specialized cells producing a prorenin called juxtaglomerular cells. Upon activation by drop in blood pressures, a prorenin is cleaved to form renin, which is released into the blood. Renin converts plasma protein called angiotensin, produced by liver, into angiotensin 1, which is a peptide of 10 amino acids, and angiotensin 1 is further converted into angiotensin 2 and 8 amino acid peptides by the angiotensin converting enzyme ACE, predominantly present in the lungs and kidney. Angiotensin 2 is a hormone. It binds to angiotensin 2 receptors in tissue to exert various effects. It promotes sodium resorption in proximal convoluted tubules of the kidney. It stimulates vasoconstrictions in systemic arterioles. It includes the release of aldosterone from the adrenal cortex, which is aldosterone promotes sodium and water retentions in the kidney. In the central system, angiotensin 2 has several effects. It acts on the hypothalamus to stimulate thirst and encourage water intake. It induces posterior pituitary to release antidiuretic hormone which promote water retention by the kidney. And third, it reduces the sensitivity of baroreceptors response to increased blood pressure, so that in response would not counter the effect of the renin-angiotensin system. All this action lead to an increase in blood volume and the blood pressure. Angiotensin 2 is short-lived with half-life of 1 to 2 minutes. It is segregated into angiotensin 3 and 4, which have lesser effect. Overactive or improperly activated RAAS is a cause for hypertension, as we can see in the couple of slides coming soon. RAAS is a frequent target of antihypertensive drug. ACE inhibitor and angiotensin receptor blocker are common treatment for hypertension. As I mentioned, the kidney secrete the enzymatic hormone renin in response to reduce sodium fluoride, extracellular volume, and arterial blood pressures. Renin activates the angiotensin, a plasma protein produced by the liver, into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 as we see in the figure by angiotensin converting enzyme ACE, which is produced in the lungs. Angiotensin 2 stimulates the adrenal cortex to secrete the hormone aldosterone, which stimulates sodium reabsorption by the kidney. The resulting retention of sodium exerts an osmotic effect that hold more water in the extracellular volume. Together, the conserved sodium and H2O help correct the original stimuli that activated the hormonal system. Angiotensin 2 also exert other effects that help certify the original stimuli, such as by promoting arterioles vasoconstriction. In this slide, I'm going to talk about the activation of the renin-angiotensin-aldosterone system. So the most important and best known hormonal system involved in regulating sodium is the renin-angiotensin-aldosterone system. The granular cells of the juxtaglomerular apparatus secrete an enzymatic hormone, renin, into the blood in response to fall in the sodium chloride, extracellular volume, and arterial blood pressures. This function, in addition to the role of the macular dense cells of juxtaglomerular apparatus, play in autoregulations. The following three input to the glomerular cells increase renal secretion is: first one is the granular cells themselves function as intrarenal parareceptors. They are sensitive to pressure changes within the efferent arterioles. When the granular cells detect a fall in the blood pressure, they secrete more renin. The second one is the macular dense cells in the tubular portion of the juxtaglomerular apparatus are sensitive to the sodium chloride moving past them through the tubular lumen. In response to fall in the sodium chloride, the macular dense cells trigger increased renin secretion. The third one is the glial cells are innervated by the sympathetic nervous system. When blood pressure falls below normal, the baroreceptor reflex increases sympathetic activity. As part of this reflex response, increased sympathetic activity stimulates the granule cells to secrete more renin. These interrelated signals for increased renin secretion all indicated the need to expand the plasma volume to increase arterial pressure to normal in the long term. Through a complex series of events involving RAAS, in this slide I'm going to talk about the function of the renin-angiotensin-aldosterone system. There are two distinct types of tubular cells are located in the distal collecting tubules: principal cells and intercalated cells. The more abundant principal cells are the site of actions of aldosterone and vasopressin, which are water-conserving hormones, and thus are involved in sodium resorptions and potassium secretions, both regulated by aldosterone, and in HTO resorptions regulated by vasopressin. Intercalated cells, by contrast, are concerned with the acid-base balance. Among its action, aldosterone increases sodium reabsorption by the principal cells of the distal and collecting tubules, as we see on the figure over there. It does so by promoting insertion of additional sodium-potassium leak channels into the luminal membrane and additional sodium-potassium pump into the basolateral membrane of these cells. The net result is the greater passive movement of sodium into these distal and collecting tubular cells from the lumen and increased active pumping of sodium out of the cells into the plasma. That is an increase in sodium resorptions, with chloride following passively. RAAS thus promotes salt retention and a resulting HTO retention and rise in arterial blood pressures. Acting in a negative feedback fashion, this system alleviates the factor that triggered the initial release of renin, namely cell depletions, plasma volume reduction, and decreased arterial blood pressures, as we see in the figure over here. In addition to the stimulating aldosterone secretion, angiotensin II is a potent constrictor of the systemic arterioles, directly increases blood pressure by increasing total peripheral resistance. Furthermore, it stimulates thirst, increasing fluid intake, and stimulates vasopressin, increasing HTO retention by the kidney, both of which contribute to the plasma volume expansion and elevation of arterial blood pressures. As you will learn, there are other mechanisms related to the long-term regulation of the blood pressures, and extracellular volume osmolality are also important in controlling thirst and vasopressin secretion. The opposite situation exists when the sodium load, extracellular volume, and plasma volume and arterial blood pressure are above normal. Under these circumstances, renin secretion is inhibited. Therefore, because angiotensin is not activated to angiotensin 1 and 2, aldosterone secretion is not stimulated. Without aldosterone, the small aldosterone-dependent part of the sodium reabsorption in the distal segment of the tubules does not occur. Instead, this non-absorbed sodium is lost in the urine. In the absence of aldosterone, the ongoing losses of this small percentage of filtered sodium can rapidly remove excess sodium from the body. Even though only about 8% of the filtered sodium depend on aldosterone for reabsorption, this small loss multiplies many times as the entire plasma volume is filtered through the kidney many times per day, can lead to sizable loss of the sodium. The amount of the aldosterone secreted and consequently the relative amount of salt conserved versus salt excreted varies depending on the body needs. For example, an average salt consumed typically excreted nearly 10 grams of salt per day in the urine. A heavy salt consumer excrete more, and someone who has lost considerable salt during heavy sweating excrete less urinary salt. With maximum aldosterone secretion, all the filtered sodium and accordingly all the filtered chloride is reabsorbed. So salt excretion in the urine is zero. By varying the amount of renin and aldosterone secreted in accordance with the salt determined fluid load in the body, the kidney can finally adjust the amount of salt conserved or eliminated. In doing so, they maintain the salt load, extracellular fluid volume, and arterial blood pressure at relatively constant level despite wide variation in salt consumptions and abnormal losses of salt-laden fluid. Some cases of hypertension are the results of abnormal increases in RAAS activity. This system is also responsible in part of the fluid retention and edema accompanying congestive heart failure. Because of this failing heart, cardiac output is reduced and the blood pressure is low despite a normal or even expanded plasma volume. When a fall in blood pressure is the result of falling heart rather than a reduced salt and fluid load in the body, the salt and fluid retaining reflexes triggered by the low blood pressure are inappropriate. Sodium exaggerations may fall in a zero despite continuous salt ingestion and accumulation in the body. The resulting extracellular fluid expansion reduce edema and intensify the congestive heart failure because the weakened heart cannot pump the additional plasma volume. And here are my references. Thank you for listening. God bless you all.